Welcome everyone. We will decode diabetic ketoacidosis, or DKA, one of the most critical endocrine emergencies. By the end of this video, you will understand the biochemical story behind the DKA triad, the fluid shifts, and the potassium paradox. DKA's core defect is an extreme metabolic imbalance. Insulin deficiency, combined with surging counter-regulatory stress hormones like glucagon and cortisol, shifts the body into an unrestrained catabolic state. This creates a paradox. The blood is full of glucose, yet the cells are starving. DKA is defined by a triad: hyperglycemia, hyperketonemia, and metabolic acidosis. These are not independent. They arise from the central problem of insulin deficiency and hormone excess. Understanding this linkage makes the diagnostic laboratory findings predictable. Hyperglycemia results from two mechanisms. First, decreased peripheral uptake, as cells are locked out of glucose. Second, unrestrained hepatic production through glycogenolysis and gluconeogenesis. The resulting high glucose does not solve the cellular energy crisis. Once glucose exceeds the renal threshold, it spills into the urine. Glucose acts as an osmotic magnet, pulling water and electrolytes into the urine. This profound osmotic diuresis leads to massive systemic dehydration and severe loss of sodium and potassium. The fluid shifts in DKA involve both compartments. Initially, hyperglycemia pulls water out of cells into the extracellular space. As osmotic diuresis continues, the extracellular volume collapses, leading to hypotension, decreased blood volume, and renal impairment. Reduced renal perfusion activates the RAAS system, causing secondary hyperaldosteronism. This aggressively retains sodium, but at the expense of massive potassium excretion. This compounds the severe urinary potassium loss already caused by osmotic diuresis. Unrestrained lipolysis in adipose tissue floods the bloodstream with free fatty acids. The liver rapidly converts these into acidic ketone bodies, acetoacetate, and beta-hydroxybutyrate. This uncontrolled ketogenesis is what drives the life-threatening metabolic acidosis. Ketone production drastically outpaces the body's ability to metabolize them. The accumulation of these acids consumes bicarbonate buffers, causing a drop in blood pH and a high anion gap metabolic acidosis. This critical acidosis threatens systemic cellular function. The acid shift causes hydrogen ions to enter cells for buffering. To maintain electrical neutrality, potassium shifts out into the bloodstream. This displacement artificially raises or normalizes serum potassium despite profound total body potassium depletion. The potassium paradox is a lethal illusion. Every DKA patient is potassium depleted, but initial plasma levels are falsely reassuring. When IV fluids dilute the blood and insulin drives potassium back into cells, plasma potassium will crash, potentially causing fatal arrhythmias. Clinical signs are manifestations of the underlying pathology. Kussmaul breathing is the respiratory attempt to compensate for acidosis. Polyuria is due to osmotic diuresis, and hypotension is the result of severe fluid loss. Delirium results from hyperosmolality and acidosis. DKA is no longer exclusive to type 1 diabetes. It is emerging in type 2 patients and, importantly, in those using SGLT2 inhibitors. This can cause euglycemic DKA, where severe acidosis occurs without extremely high glucose. Never rule out DKA based on glucose alone. DKA is a lethal synergy. Hyperglycemia creates hypovolemic shock, while ketogenesis creates acidosis. The failing kidneys, unable to clear the toxic ketones due to hypoperfusion, accelerate this metabolic spiral. Treatment must rapidly interrupt this cycle.